Hi, thank you for joining us. I'm your host, Nada Youssef, and today we're talking about osteoporosis. Osteoporosis weakens bones, making them susceptible to sudden, unexpected fractures. The disease often progresses without any symptoms or pain and is not found until bones fracture. Today we will talk to our Cleveland Clinic experts regarding steps you can take to prevent this disease and treatments that may be needed. And here with us today we have two experts. We have Associate Professor of Medicine for the OBGYN and Women's Health Institute, Dr. Pelin Batur. Glad to have you. And we also have with us Head of the Center for Osteoporosis and Metabolic Bone Disease and Rheumatologist, Dr. Chad Deal.
Thank you.
Thanks for having you as well. I want to start, first of all, with Dr. Batur. I want to explain to myself and to the audience why we need a women's health aspect to this, why it's important that you're here.
Yeah, hormonal treatments are can be very, very helpful for bone because obviously for most patients with osteoporosis, it's going to be postmenopausal women who have lost estrogen, and hormone therapy, which we'll talk about a little bit more. There's a better understanding of risks versus benefits, and it's, there was a scare many years ago that it's a lot of risk and not much benefit, and now we really understand that depending on the woman, you can really get a lot of benefits from hormones, bone health being one of them. And sometimes we use hormonal treatments to minimize the duration of use of our other bone agents. So we really work closely together between Women's Health and the Osteoporosis Center to help treat our patients.
Sure, excellent, thank you. And for our viewers, whoever's watching, you can leave your questions in the comment section below. If you have any questions, we'll ask them live here. And before we begin, please remember this is for informational purposes only, and it's not intended to replace your own physician's advice. All right, so let's start, Dr. Deal, with explaining what is osteoporosis.
So most people know osteoporosis as a disease that causes fractures. Prior to that, though, for a very long time, you can have osteoporosis and not even know it. And it's basically what we call a micro-architectural deterioration of bone. So think of a skyscraper as it goes up with all these girders, and as time goes on in your bone, you're missing a few of those girders, which creates weakness, and the weakness gradually accumulates until you have a fracture. So it's really important for both men and women to get a test for osteoporosis prior to the fracture, because in most cases we can actually prevent the fracture if we know that the patient has either osteopenia, which is a little bit not quite as bad as osteoporosis, in advance, and use some of the drugs, whether it's hormone replacement or bisphosphonate therapy or many of the other drugs that we have.
Okay. So before a fracture ever happens, are there any symptoms that the patients may be feeling and not knowing that could be osteoporosis?
Right, and that's why we've called it the silent thief.
Yes.
So people generally, they don't have any symptoms until a fracture occurs. So that's very different than, for instance, osteoarthritis, where if you have it in your knee, you're going to have stiffness and swelling as an early warning sign that the joint is deteriorating. But with osteoporosis, no. You have no symptoms.
All right. And then who's at risk? I know women are definitely at risk. I know it's called also a woman's disease, correct? Some people refer to it.
There's a lot of men that are underdiagnosed, so it's not just a woman's disease, but it is most common in women after menopause. So we're really looking at anybody who's lost their sex steroids. So that would be estrogen for women and testosterone for men. Also, patients who have been thin throughout their life, which we define as less than 127 pounds. That's a risk factor. Certain medical conditions, diabetes, rheumatoid arthritis, will increase risk. Those who've had a previous fracture are at a risk for another fracture. And we also look closely at the medication list. So, for example, women who've had chemotherapy, for example, for breast cancer, and are now taking anti-estrogen treatments, people who are taking steroids. So those would all be things that we look at the med list to see if they're on a medication that could increase their risk.
Is age a big factor as well?
Age is one of the biggest factors.
Okay, why is that?
So if we look at any bone density, and let's say somebody has a bone density that's in the osteopenia range, not quite osteoporosis, and they are 50 years old, their risk of fracture is going to be much lower as opposed to somebody with that same bone density who's now 65. So in fact, for each 5 years that passes after age 65, you're essentially doubling your risk of fracture. So age is one of the biggest things that we worry about for fracture risk.
Okay. And then, so the cause is unknown, but how does that disease develop?
Well, we do know a lot of the causes for low bone mass or osteoporosis. About 70% of peak bone mass is genetically determined. So by the time you're 25 or 30, 70% of your bone mass is done.
Wow.
That's why it's really important to have a healthy lifestyle as a youth. That includes not smoking and low alcohol intake and lots of exercise and normal body weight. But there are environmental issues, as Dr. Batur has already mentioned, that affect peak bone mass.
Sure.
Okay,
Sure.
so so a lot of the times it's known, but the genetics of it are very complex. There are at least 100 genes or more that control peak bone mass, bone loss. So you might think of genes that control vitamin D metabolism or calcium absorption or osteoblast function. These are the cells that produce new bone, or osteoclasts, the cells that break down bone. So there are lots of genes involved that we don't understand.
Sure, sure. Are there certain diseases or medical conditions that contribute to bone loss more than others?
Yeah, so the reason I'm here, I'm a rheumatologist. I got interested in this because many of my diseases can result in bone loss. One would be rheumatoid arthritis. In fact, rheumatoid arthritis is a risk factor. If you go to this FRAX website, if you just Google in FRAX on your computer, you can calculate your 10-year risk of a fracture. And rheumatoid arthritis is one of the risk factors. In addition, for all the inflammatory diseases that rheumatologists treat with steroids, that's a huge risk factor. So we're talking about cortisone, prednisone, those types of medications.
Right, right.
They're very big risk factors. But it's not only rheumatology. All subspecialties use steroids or prednisone as part of their treatments for various inflammatory diseases.
Right, right. And the medications can also, there are some medications that can cause some bone loss?
Well, I think Dr. Batur also already mentioned aromatase inhibitors in women with breast cancers. Those are anti-androgen therapy.
Right.
For men, is anti-estrogen, anti-androgen therapy in men with prostate cancer, for instance. That's a big risk factor. But there are others like seizure medication, Dilantin, that accelerate vitamin D metabolism and can cause low bone mass. So there are lots of medications that can do this, can accelerate the process.
Sure. Okay, and now let's switch on to the dietary factors, and you talked about that a little bit. Even when by the age 25 or earlier, you should be healthy. Let's talk about diet. Is there dietary factors that can contribute to this disease?
I'm glad you're asking me this question because I'm going to keep rewinding this for my kids.
Okay, so good. That's
just
important.
Like you said, by 20, 30,
yes.
We're building up some put on repeat.
Yeah.
I mean, what you're doing throughout your youth and with your lifestyle, it really makes a big difference. So we want to make sure that patients are getting enough calcium. We prefer dietary calcium as opposed to supplements whenever possible.
Okay.
Realize that that's not always possible. We have patients, who have gastrointestinal issues or lactose intolerance. They may not be able to get adequate dairy calcium, or dairy is your best way of getting calcium. There's other ways, but if you're lactose intolerant, it's going to be hard for you to get that. So getting enough calcium is probably one of the most important things. And truth be told, nobody knows exactly how much calcium is required. There's some controversy with that, but we think somewhere around 1,000, 1,200 milligrams a day.
Okay.
And I see people who are either getting way too little calcium or sometimes getting way too much, because that amount, the 1,000 to 1,200, should be everything, including supplements and what's in your diet.
Okay. So there could be too much calcium. That can also cause to bone loss.
It won't cause bone loss, but adding extra calcium is never going to help you to build your bone. Either you're going to pee it out, or there's some concern about whether, it leaches out into the arteries. Calcium is a safe supplement overall, but just like anything else, too much you want everything to be in moderation. Too much of anything isn't good. Plus, it's constipating. Most types of calcium.
Right. What about lifestyle choices?
So lifestyle includes exercise. You're talking about things like that.
Yes.
So the good example of exercise would be as if you go into space, you lose about 1 to 2% of your lumbar spine bone density every month. So that's total weightlessness. So obviously that's not something that our audience is going to experience. But if you're a couch potato, you can lose bone mass, not to that extent too. So weight-bearing activity is really important. And when I say weight-bearing, I'm not talking about lifting weights. We're talking about heel strike. So putting your foot to the floor and sending a mechanical stimulus through your skeleton. We have cells in our body called osteocytes that are mechanoreceptors, and they take that vibration and they turn it into something that stimulates osteoblasts to produce new bone.
Wow.
So that kind of lifestyle is really important. I think we've already mentioned calcium, we've already mentioned smoking.
Smoking and drinking.
Alcohol. Alcohol is a direct toxin to osteoblasts. The kind of the cut point for that for men is about 3 drinks a day, 21 a week. It may be less for women. Are toxic to the cells. Smoking, nicotine is really bad for your bone.
Yeah.
There's nothing nicotine is good for,
Right, that's
including the bone.
Sure, sure. And even those guys in space have treadmills, and they have certain things to do to keep their bones strong, right? Because
Yeah, they
can
do.
lose a lot of bone
And
mass.
you know, the Cleveland Clinic was involved in a project to try to do what we call counteract the effects of weightlessness, so that we can go to Mars. And in order to do that, you've got to do some kind of weight-bearing activity going to Mars and back. Otherwise, you're in real trouble. And so that's an experiment that's still ongoing at NASA in Johnson City, but it started at the Cleveland Clinic.
Wow, that's amazing. I didn't know that.
And I think it's important to emphasize, it's not just about taking a supplement or getting half an hour of working out in a day. It's really about lifestyle, you know, eating nutritious foods, taking good care of yourself. And I do see people who are taking a bunch of supplements, but they go on these fad diets, and they lose a bunch of weights that, you know, of course we want you to be a healthy weight, but they do it through eliminating of a lot of wholesome foods.
Sure.
And then I see a huge decline in their bone density, you know, the year after. So it's really, there's a lot to be said for just taking plain old good care of yourself.
So it's kind of reversible. Like you can fix. Is that if your bones are starting to be weak, you can fix it with your lifestyle and dietary choices?
Yeah, to a certain extent.
Sure. Okay. Well, we talked about how there's no signs or symptoms for osteoporosis, but I know you mentioned earlier there's a test that people should take. What age? Who should take it? And what tests are we talking about?
So the guideline, my guideline is a little bit different than the official guideline. So the official guideline is every woman at age 65 should have a bone density test. But if you have clinical risk factors for bone loss, you know, so that would be low body weight or smoking or family history or previous fracture, it really should be at menopause, because so many women enter menopause with low bone mass already, and there's a subset of women that can lose up to 5% of their bone mass every year for 6 years. You can lose a third of your bone mass in a 6-year period. And the only way to really attack that is to know if you need to treat it right away, and a bone density test is the best way to do that. For men, the guideline is age 70, unless there's risk factors, in which case we do it at age 50.
Okay. And this, we're talking about like a bone density test.
Yeah,
correct?
and it's a $100 test. It's part of Welcome to Medicare. So when you go get your Medicare insurance, that's part of the test. It's covered by Medicare, but most commercial insurance will pay for it if you have risk factors. And I think it's a test that's well worth the $100, even if you had to pay for it yourself in order to maintain skeletal integrity and prevent fractures.
Can you describe to the audience, kind of like walk through what kind of test, like what does it look like? What to expect going into a bone density test?
It's really easy. It takes about 5 or 10 minutes. You lie on a table, and there's a X-ray beam that sends a X-ray through your skeleton, the hip and the spine, and the amount of X-ray that gets through the bone and is detected on the other side is proportional to the amount of calcium in the bone. Okay. And when I say X-ray, remember this is a very low X-ray procedure. It's about 1/10 of the amount of X-ray of a chest X-ray. It's about the same amount of radiation you get flying from Cleveland to San Francisco. So it's not something you should worry about in terms of X-ray exposure.
Good. That's going to be my next question.
Yeah.
Okay, let's jump on to treatments. I want to talk to you about treatments, what treatments there are, and I know for women it's probably different for men, so we'll kind of tag team and talk about that.
Yeah, we have lots of treatments available. So we have hormonal treatments, which technically the hormone replacement therapy for the younger woman is meant to be for preventing osteoporosis and fractures. But we do have great data, many years of data that suggests it actually helps prevent fractures and hip fractures, which is important because not all medications available have been shown to prevent hip fractures, which is one of the types of fractures that we really worry about, because that's the one that can really impact affect disability in terms of putting you into a nursing home or increasing your chance of having a bad outcome and increasing death. So that's where hormone therapy can be very helpful, especially for the younger woman who's got pretty severe bone loss. But we have many non-hormonal options available. We have what we call also designer hormones. So these are called selective estrogen receptor modulators, SERMs, or sometimes people call them estrogen receptor agonists, antagonists. But really what the name is trying to define is that it works like an estrogen in some body parts and as an anti-estrogen on other body parts. So, for example, the one that we have approved for bone health is an anti-estrogen at the breast. So it's also used for breast cancer prevention. I would define it as a little bit of a weaker bone medication. So this is probably a perfect ideal candidate for that one would be a younger woman that has significant bone loss, and she has a family history of breast cancer, okay? And she wants to prevent that risk, but her risk of fracture right now isn't that high because she's still younger. And so what you can do is you can kind of insert that therapy for 5 years or so you kind of postpone when she's going to switch over to another therapy. And I'm sure we'll talk about that. There's bisphosphonates. These are the bone medications that come in pill form, injectable form, oftentimes just taken once a week or once a month. And then we have also bone builders and other injectables.
Great. Would you be taking the same approach? I know you're more of a...
absolutely, yeah.
Okay.
So the bone builders, what Dr. Batur was mentioning, are our anabolic. So we divide therapy into anabolic or bone building and anti-resorptive, and the anti-resorptives prevent bone resorption or bone breakdown, and those include estrogens and the SERMs that were mentioned along with the bisphosphonates. The bone builders, we have 2 of them now. We have Forteo and Tymlos, and they're both PTH analogs, PTH being parathyroid hormone. And they're injections, and they're expensive, but for patients at high risk for fracture, who've already had fracture, who have very low T-score, they're our kind of go-to drug for the severe osteoporosis case. And I think they're underutilized and should be considered in patients with severe osteoporosis.
Sure. Now,
I was going to say for the bisphosphonate medications, you may have been asked, were going to ask me that. There's a real fear of using these medications now. And the 2 things that people think about as side effects are these atypical fractures or this brittle bone and osteonecrosis of the jaw. So I always tell my patients there's no free lunch. There's always a risk to everything you do. You could take an aspirin tablet, swallow it, and it could stick on your esophagus, and you could burn a hole in your esophagus if you don't do it properly. So our job as osteoporosis specialists are to treat people at high risk for fracture so that the benefit of the drug outweighs the risk. Now, having said that, atypical fracture risk is with these drugs. These are thigh bone or hip fractures that occur spontaneously with long-term therapy. They don't really occur in the first 3 years of bisphosphonate therapy. They're issues related to long-term therapy. And for that reason, we have guidelines now for drug holidays with bisphosphonates. So
drug holidays.
People with mild or moderate risk might be on the drug for 3 to 5 years, and then they get time off for good behavior. But it's not really time off because these drugs, the bisphosphonate medications, bind to bone. They stay there a long time. So I call it an administrative holiday, but the drug's still actually working in the system. That's not true. That's not true for estrogens. That's not true for SERMs. That's not true for anabolics because once you stop those, the effect goes away very rapidly.
And then we also have another injectable called Prolia, and that's actually helpful for our patients who have bad kidney, kidney dysfunction. And so patients with weakly functioning kidneys oftentimes can't tolerate some of the other bisphosphonate medications. And this is an injection done like a flu shot, essentially, getting it twice a year at the doctor's office, and tends to be well tolerated. So the point is, we really have a lot of options, and we use all of these medications regularly. So it's about, the individual person, what's in their medical background, what are their priorities, what do they feel comfortable with, and we take it from there. And oftentimes we will change the medication that we're using over time. So the long-term medication, the side effects that you were mentioning, the osteonecrosis of the jaw, the unhealing wounds of the jaw, and the femoral neck fractures. So these seem to be an issue with longer-term use. So oftentimes, if it's a younger woman, we can use something hormonal for 5 to 10 years, and then we know that when we take her off the hormones, that bone density is going to drop, and then now she's in her 60s, and maybe she doesn't need the hormones anymore because she's not having any hot flashes. Then we can step in with our other bone agents patients, and that way we're minimizing their duration of use.
Sure.
So we're maximizing the benefit, but minimizing some of those long-term
Very
risks.
good. Very good. And we're getting a lot of questions. We'll get to them here in a second. But first, Dr. Deal, I want to talk about osteoporosis in men. Is it common? Or is it more common than we think?
More common than you think.
Okay.
About 20% of all hip fractures are men.
20%.
Yeah, so it's a substantial minority. So there are two differences with men from women, or maybe more. But one is men have higher peak bone mass, so about 10% more peak bone mass. So that means that they fracture later in life, if they do fracture. And the second thing is they don't have abrupt decline in hormones like women do at the menopause. Testosterone decline is much more gradual over time. So that tends to protect them from fractures, but not totally. As I mentioned, 20% of all hip fractures are men. And the same risk factors that we've talked about already for women apply to men. So healthy lifestyle, calcium, vitamin D intake, smoking, alcohol, they all apply to men.
And I don't think we touched on this. There are primary and secondary osteoporosis. Can you explain these two main types and what causes second osteoporosis in men?
That's a kind of a nomenclature term. Primary is when there's no apparent secondary cause like rheumatoid arthritis or steroid use or vitamin D deficiency. And those are mostly, just the genetics of it. And the secondary causes are those that we can identify a definite reason for the osteoporosis and hopefully intervene and do something about it.
Okay. And then the risks don't differ for men, correct? The risks are both for women and men the same.
There's almost total overlap in risk factors for osteoporosis between men and women.
Okay, great. Thank you, guys. Well, I'm going to go ahead and head to some live questions that we're getting. I have Brandon. Dairy calcium source versus non-dairy calcium source, which is better?
So as long as you're getting your calcium and it's through a natural food source, that's okay. I don't think one is necessarily better than the other. I usually give a printout of how much calcium is in different foods, and you can actually find that on our Cleveland Clinic website because I oversee a lot of the Women's Health Cleveland Clinic patient education materials for the hospital. So if you Google Cleveland Clinic patient education, you'll have a whole bone section that goes into vitamin D and calcium, and we try to update those every few years so that they're up to date with accurate information. So I think it's important for everybody just to add up their typical average day calcium intake. And you can do that with fancy Google calculators or apps, or you could just do simple arithmetic. And just see, because on our website it lists different types of foods and how much calcium per serving. One thing to keep in mind, some of the green leafy vegetables, sometimes our body has a harder time extracting the calcium from those. So I always tell people don't underestimate with those, or don't overestimate. So be accurate. If you're saying, oh, that looks like about a half a cup of kale, don't say that's half a cup of kale. I mean, really look at your intake, because you might not be getting quite as much calcium from some of the green leafies.
Great. Good to know.
And then
that was Brandon, right?
Yes.
That asked that.
Yes.
He may be getting at whether, if you go to a website, a vegan website, there's lots of information about calcium from dairy versus non-dairy source. So there's a fair amount of controversy. I think that Dr. Batur and I agree that food calcium from any source is probably good, but there is controversy in that area.
Right.
And I think one important thing to bring up is that your body typically can only absorb about 500 milligram calcium at one time. So what I see a lot of times is somebody who sat down with their fortified cereal, had their fortified orange juice, put their milk, took their multivitamin. They said, I'm done for the day. Your body is very smarter than us. It controls how much calcium it's going to absorb. So it's one thing, if you're trying to make sure that you're getting the right amount of calcium intake, break that up throughout the day. So don't take a supplement when you already took a multivitamin, because you're probably going to just poop that out.
Yeah. Great. And then Shirley, what are things you can do if you already have osteoporosis as a result of Crohn's and other health issues?
So, Crohn's disease, there are a couple of reasons that people with Crohn's have low bone mass. One is many of those folks with inflammatory bowel disease have been on steroids or prednisone, which can cause bone loss. Second reason is that especially if they've had surgery, they may have malabsorption and they may not absorb calcium and vitamin D very well at all. Many patients might have low body weight, and that's another risk factor. So when you talk about therapy for those folks, you've got to address all those issues and correct to the extent you can all those issues. And if they still have low bone mass, then that's where you step in and use one of the active drugs that we have to either prevent bone loss or build up bone.
Sure, sure. Now, I wanted to ask you, where do you go for that bone density exam test? Do you go to your primary care physician? Do you need to see a specialist?
Well, so bone density machines used to be more prevalent, and they used to be in many, many primary care offices. But over the last decade or so, reimbursement for bone density has declined rapidly, and many bone density machines in private offices have gone away. So often they're in hospital-based radiology departments, but there's still a very significant number in private offices. It's the machines cost about $50,000, $60,000, $70,000. They're not too expensive, but they're not too cheap.
Right.
And it's fairly easy to find one.
Okay, great. Thank you.
You do. It's helpful to make sure that you're getting your bone density on the same machine, so that when you in 2 years when you're following up on that you can actually so you can compare change, because it's like otherwise getting on a scale and trying to determine 1 or 2 pounds difference on different scales.
Right.
And we take great pride. I mean, both Dr. Deal and I read thousands of scans per year, and so at our institution we take great pride in making sure that we're all certified and that we're following the International Society guidelines. So you want to make sure that you're getting it from a professional place and following up on the results there.
Sure. Great. Thank you. Chris, for women who have been diagnosed with breast cancer and are taking estrogen blockers, what are the natural therapies that they can use to prevent their bones from thinning?
So I'm assuming when they say natural, Chris, you said was thinking about like supplements.
I guess so, yeah.
So let me address that first. So, because I get that question a lot. In terms of soy supplements, that's one of the most common questions that we get. Soy can have estrogen-like properties, and so our oncologists get a little nervous about their use in supplement form, because when we look at plant estrogen, even though it's found in nature, it's completely unnatural to our body chemistry. We don't have estrogen that looks like that. So on our website that I mentioned, the calcium sheet, it also talks about the hormone therapies, and there we talk about different amounts of soy and how much estrogen they have. So if you're doing it naturally through diet, I think that's okay, but when you're doing it in supplement form, I get a little nervous.
Okay.
People also take strontium sometimes for as a supplement, and the recommendation is to not use that. People use fluoride. In fact, if you're just looking at bone density data, fluoride is probably going to help improve your bone density more than many other products that we have. But why don't we use it? It probably increases the risk of fractures.
Sure.
So the medications that we recommend have been really tested, and we're looking at outcomes like fracture data. So the problem with some of the supplements, although they're labeled as natural, we don't really have safety data.
FDA.
Right. Yeah. So I mean, I recommend supplements in my practice, but I'm a little nervous because in terms of osteoporosis health, bone health. Outside of the calcium and vitamin D, we don't have data about safety or effectiveness of others.
Right. So it's okay to eat soy diet in your diet, but not supplements. Probably stay away from that.
Right, and as long as you're not overdoing it.
Okay.
Yeah. Again, some of our oncologists do it because depending on the type of breast cancer treatment you're receiving, some like tamoxifen, for example, work by really competing for that estrogen receptor. So if you're getting a little extra estrogen from a lot of soy, it's probably okay. But for medications like aromatase inhibitors, which function by really dropping that estrogen level, the oncologists really worry about any kind of estrogen seeping into the system, that it may actually make it not work as well.
All right. And then I have Gloria. I have osteoporosis. What can I take to relieve stiffness and pain as I am on warfarin?
So she doesn't have stiffness and pain from the osteoporosis. As we mentioned, it's silent.
Right.
So her stiffness and pain is probably related to degenerative joint disease, or I'm not sure where the stiffness and pain is.
Right.
And that's a different issue for stiffness and pain, other than physical therapy and stretching and heat and all the non-medical, non-medicine type of therapies. We often use non-steroidal anti-inflammatory drugs for stiffness and pain, but that's really not related to osteoporosis.
And that's why it's called silent bone thief, right? Because
Correct.
you never know what's happening.
Correct.
And I think the big source of confusion is because they both have the term osteo in it, which means bone, but osteoporosis literally means porous bone, so it's weaker, and osteoarthritis, which causes a lot of the pain, means inflammation.
Okay, great. And then Bonnie, I'm a kidney transplant patient and on prednisone and work out and walk a lot. What else can I do to stop the pain? More pain questions.
More pain?
Yeah, we have a few
Well,
pain
I don't know why
questions.
she has pain, so that's a hard one to answer. Sorry.
Yeah.
Yeah, it needs an evaluation probably with rheumatology.
Okay, great. So I'm going to go ahead and see here. We got Lydia. What are the pros and cons of, tell me if I'm doing this wrong, is it reclassed infusion?
Reclass.
Yeah.
Reclassed infusion?
So the reclass is one of the bisphosphonates that we mentioned. Well tolerated. We have great data on the effectiveness. It's given once a year, and we use it for at least 3 to 5 years, and then do a bone holiday for most people, unless it's severe. And really, there's not many contraindications. So one of the reasons we wouldn't use it if somebody had significant kidney dysfunction, we'd be hesitant about that. But one of the nice things about the injections is that we're guaranteeing that it's being absorbed. So when a patient takes an oral pill, like for example, if they take oral Fosamax, roughly about 1/1000th of that is absorbed. So if they're not taking it properly on an empty stomach, they're drinking it with their coffee, absorption might be an issue. Or if somebody has bowel issues that prevent absorption. So at least we're bypassing all that and we're ensuring that it's absorbed. And also if somebody does have issues with, reflux, esophagitis type of symptoms from the pills, then the IV formulation helps bypass that.
And it's a simple, infusion. It takes about 20 minutes. You do have to have an IV.
Right.
About 10% of patients get a post-infusion reaction. We call it flu-like. It's not the flu, but they may have low-grade aches and pains, low-grade fever for 24 to 48 hours.
And that's 10% of.
Yeah, it's a Medicare B drug, so it's covered very well by Medicare. The out-of-pocket expenses are usually very small. It actually went generic a few years ago, and the price, for instance, of that drug is like $350 for an infusion once a year. So it's really actually very cost-effective medication.
Great.
They're actually using it in oncology too, some of these medications and bisphosphonates to prevent metastasis to the bone. So there's probably some other health benefits that need to be more studied.
Sure. And I have another question about another medicine. Allison wants to know, what are the pros and cons of Prolia?
Right, and I think Dr. Batur mentioned Prolia. Prolia, so we've talked about bisphosphonates that are chemicals, and they bind to bone, and when an osteoclast comes along the bone surface to resorb the bone, the bisphosphonate's taken up and the osteoclast function is inhibited. Prolia, or denosumab, is completely different. It is a monoclonal antibody against rank ligand. Rank ligand is a cytokine that's absolutely essential for osteoclast function, osteoclast being the cells that resorb bone. It's a shot given every 6 months. When you stop this drug, the effect goes away very rapidly, so we're not talking about drug holidays with this drug. It's a very effective drug. We actually have a 10-year study now in 2,500 people showing its safety over a 10-year period. It does have some of the same side effects as the bisphosphonates, including rarely these atypical femur fractures or osteonecrosis of the jaw. I should say something about ONJ, osteonecrosis of the jaw. 90% of patients who get that tend to be the cancer patients who are getting the high-dose medications Dr. Batur mentioned. If they have cancer, they tend to get reclassed or Prolia in super high doses, 10 times the osteoporosis dose. About 5 to 10% of these ONJ cases are in osteoporosis patients, but in most cases these are patients who have dental procedures that involve exposed bone, like a tooth extraction or very poor dental hygiene. So that for that reason, when we're starting one of these drugs on a patient and they have some dental issues, we always like them to get those dental issues cleaned up and taken care of before we start the medication.
Sure.
And one more plug-in for the hormonal therapies. So the hormone therapies and the SERMs that I mentioned, they have not been linked to some of these long-term risks, such as of the jaw and of the femoral neck. So for women who are appropriate candidates or who are suffering with a lot of menopausal symptoms, they can't sleep, vaginal dryness, a whole menopause complex mood concerns. This is a way that you can avoid the long-term use of one medication.
Yeah, and the anabolic drugs, the bone builders, Forteon, Tymlos, they're not associated with atypical fractures or ONJ either.
Wow. All right, and then we are having questions about Fosamax. So Terry wants to know, are there natural treatments without taking drugs such as Fosamax?
So similar to what we talked about before, there's really no
Nothing
natural supplement
Yeah.
that we know that works.
Okay.
And unfortunately, you know, if we lived in a country where there was more strict regulation of the supplement market, I would feel so much more comfortable. But we're seeing increased number of liver transplants from supplements, because you can make a lot of claims on supplements,
Yeah.
because, you know, everybody wants to be healthy and there's people with money in their pockets. So it's a business model built on very little oversight by any federal, you know,
Right.
FDA.
Regulation, yeah.
Exactly. And so there's people out there to make a buck, and they may have the best intentions of putting out a pure product,
Right.
but there's issues with impurities. They found rat poison, chemotherapy agents in some of the supplements, and without the data to show that there's any supplement that helps, I'm a little nervous about recommending it.
And supplements you don't need a prescription for. You could just go get it from wherever or online,
Mhm.
correct?
Right.
Yeah,
Yeah.
that's the scary thing.
And that's
And,
yeah.
and some people, they ask me, can I do this with just calcium and vitamin D alone, for instance? And what I usually tell folks is that we have randomized control trials that led to the approval of all the drugs we've talked about
Right.
today. And the placebo group is calcium and vitamin D. So we know that when you add an active medication to calcium and vitamin D, that you reduce your risk for fracture. Calcium and vitamin D are important, and when you are on one of these medications, you still need calcium, because calcium is the building block of bone. Fosamax is not calcium. You still need the calcium.
Sure.
It's kind of a quirky analogy. I mean, it's not perfect, but I like the way it feels in my head.
Yeah.
You know, I think of calcium and vitamin D as a bunch of bricks.
Okay.
And I think of the medications that we're recommending when the bone disease is really bad as like a bricklayer. And so when you have a wall that's falling apart and the bricks need to be put together, dumping more calcium and vitamin D, so dumping more bricks isn't going to fix the problem. And having a bunch of bricks and no bricklayer isn't going to help. Or having the bricklayer, which is the medication, without the adequate number of bricks, the
Right.
calcium and vitamin D isn't going to help. So it's that delicate balance of both that you need.
Yeah, that makes sense. And then Joanne wants to know if Fosamax causes jaw pain.
Well,
Talk
jaw
about it.
pain.
Right.
So, first of all, there are lots of reasons for jaw pain. We have patients who walk in the clinic and they've stopped their Fosamax because they have clicking in their jaw, and that's TMJ. That has nothing to do with OMJ. There are many reasons for jaw pain: muscular pain, grinding your teeth at night. Everything that causes pain around in the jaw or the face is not related to Fosamax. Osteonecrosis of the jaw, there's a definition for it. It's exposed bone that persists for more than 6 weeks. So if you look in your mouth, you'll see an area of, where the gum's gone and where you can see exposed bone, and that persists. That's ONJ. The rest of the causes for pain in the jaw are something else.
Okay.
Thank you for asking that, because that comes up a lot. And let's not forget, ONJ and the atypical femoral fractures actually occur in people not on these medications.
Oh, okay.
Okay, so this is not just from these medications.
Right.
So in fact, if you look at hip fractures, it turns out a good number of them can be these atypical fractures in people not on meds.
Right.
We're just concerned that it may slightly increase the risk,
Yeah.
but these slightly increased risks that we're talking about are in the rare category,
Sure.
1 out of 1,000 or less.
Oh, wow.
Mhm.
Okay, great. And then Darlene wants to know, should I take vitamin D or D3, and what is the difference?
D2 or D3? So,
Vitamin D or D3?
so there's two types of D. There's D2, and that's usually the prescription that we write. It's 50,000 unit D2. It's plant-based. D3 is over the counter, so that's where you get 400, 1,000, 2,000, 5,000. You can just pick it up off the shelf. That's an animal source product. Okay, D3 may be a little more potent than D2, not a huge difference. So either is fine.
So D3 is the animal, you said?
And
Okay.
D2 is the vegetable.
Okay.
Consistency is the key.
Consistency.
And the nice thing about vitamin D is it's fat soluble, so it's one of the only vitamins that you can take more in lump sum. And so I always tell people, if you forgot it for a week and you say, oops, then you can actually double up the next week, and it's similar to taking it every day. And you shouldn't do that with other vitamins, but vitamin D is one that's reasonably safe, as long as you're sticking to the lower over-the-counter doses and not a high prescription dose.
And I'll follow up with Kathy's question. She wants to talk about high dosage of vitamin D. Is it safe, and do you need to take calcium with it?
Vitamin D, you ask 20 different people, you're going to get 60
Yes.
different answers. So back in the day when we really didn't have as much data on vitamin D, I would use the higher dose supplements in my practice, the 50,000 units. And I still have to in some women that have had, for example, bariatric surgery and have really hard time absorbing. But I favor finding a lower dose that they can take regularly. And that way I can see, because I've seen some people accidentally take, we use the 50,000 units sometimes 1 to 2 times a week, but I've seen people accidentally taking it once a day. So I think there's a lot more, it's more there's some predisposition to error with that.
Sure.
So I really try to find what's the minimum that the patient can use, and usually I don't recheck levels for about 3-4 months to get a real idea of the plateau. Your approach may be different.
No, it's. I agree with that,
Yeah.
and we tend to use the 50,000 in patients who really have very low vitamin Ds because we want to replete them very quickly. Because people who have really severe vitamin D deficiency can have not osteoporosis but osteomalacia. Osteomalacia is a failure of bone mineralization, and vitamin D is really required for that. So the typical patient would be patient who's had bowel surgery and they have what we call short bowel syndrome, and they come in and they have a vitamin D level of 5, normal being 30. And those folks have a lot of unmineralized bone. They have something we call osteoid in the bone. And those patients need very quick repletion of vitamin D in order to get their bone density, bone mineralized. And that's where we tend to use the bigger pills that Dr. Batur was talking about, the 50,000.
And we should probably talk about the optimal level of vitamin D, because that's also an area of confusion. So the National Institute of Medicine guidelines say anything over 20 is adequate. But really with bone health, that's for general population. But for patients who are having a lot of achiness or those with osteoporosis, many of us would feel that that's suboptimal, and we try to strive for over 30, ideally 40 to 50. I'm a little nervous about too much vitamin D. Again, since it's fat soluble, you may not be able to pee it all out, and you can get toxic on it. So although we have data on safety, at the higher ranges, even more than 100, and surfers and people who are out in the sun getting it naturally, we don't have that safety data for supplements. So I try to stick to somewhere between 30 and 80, mostly the 40 to 50 range, really. I don't know if your approach is different.
Yeah, and then the normal's 30 to 80.
30 to 80.
As I said, there is controversy about whether you need 20, whether you need 30 nanograms per deciliter, but most folks in the osteoporosis field go with 30 nanograms or greater.
Okay, great. And then Agnes wants to know, I'm on a weekly medication for osteopenia/osteoporosis. I follow the rule on an empty stomach and do not lie down or drink my coffee for 30 minutes to 1 hour. How beneficial is the injection over the pills?
So she's asking whether taking the injection, which would be Prolia, or the infusion, which would be Reclass, might be better than Fosamax. Now, if you take your Fosamax properly, as she's doing, empty stomach, big glass of water, don't have anything to eat or drink for at least 30, maybe even longer, it's going to be effective therapy. Where you get some improvement with either Prolia or Reclass are in patients who are not quite as compliant with their oral medicines, or forget their oral medicines, or take it with a cup of coffee, as Dr. Batur mentioned earlier. So in those cases, the injection or the infusion may be a better choice.
Okay, great. And then Gwendolyn, what can you do about constipation due to calcium supplements?
Yeah, so that's a good question. So sometimes just fixing the behaviors that worsen constipation is helpful. So what do I mean? Really pushing the fluids, especially when the weather starts to turn. People don't realize that they're getting relatively dehydrated because the heaters are kicking in. So I really encourage patients who are constipated to really aim for 6 to 8 glasses of water a day, minimizing other agents that are constipating. You always want to make sure that thyroid has been checked and you don't have another reason to be constipated.
Sure.
I don't want to advertise certain supplements, but it's a fiber form. Benefiber is one of our favorites in our clinic. Just staying regular with that. There's some data that calcium phosphate might be a little bit better in terms of constipation. Personally, I've seen that to be true. And you can find that it's harder to find, but you can find that in some gummies.
Okay.
Used to be able to find it as Posture D, but I think they got rid of that a while ago. I've seen it at Sam's and Costco. It's chewables.
Okay.
Right, so calcium, that brings up the point of calcium supplements come in: calcium carbonate, calcium citrate, calcium phosphate, calcium gluconate. Most patients, the most common on the market is calcium carbonate, so that's what's in Tums or Oscal or Caltrate. Citracal I find a little bit less constipating too, and the advantage of taking calcium citrate is it's absorbed independent of acid, so you don't have to take it with a meal. You can use it in patients who have a disease called pernicious anemia where they have no stomach acid. It's absorbed very well too. The disadvantage of the Citracal is the elemental calcium is less, so you have to take a bigger pill and more pills often with Citracal than you do with carbonate, calcium carbonate medicine.
It's a little bit more expensive too.
Yeah.
And then I'm glad he mentioned about the acid, because keep in mind that if you're on medications to block stomach acid, like your Prilosec, your Nexium, which a lot of people are on, then you really should stick to something like the calcium citrate as opposed to the calcium carbonate, because you're not going to absorb the calcium carbonate as well.
Sure. Okay, well, I'm going to give you one more question before I let you guys go. Lynn wants to know, what things cause me to have a higher chance of getting osteoporosis? And I'll kind of end it with that. We can talk about, because we've talked about that earlier, lifestyle choices, dietary, and then also I want to kind of touch on pain, because I feel like a lot of people were asking about pain management with this. So we want to kind of clarify everything here as a kind of our conclusion for today.
I think one thing I'll touch on for this question that we haven't touched on is women with premature menopause. So those would be defined as late before age 40. These women have accelerated not just bone aging, but heart aging and brain aging. So these women really should be on hormone therapy until the average, unless there's a reason not to be, until about age 50, 51, 52, the natural ages of menopause, so that we really don't, create osteoporosis 20 years before they were meant to. And, we oftentimes do that even if a woman went through menopause at age 43, a little earlier, but not the definition of premature menopause. So unless she has a compelling reason not to be, she usually will feel better and she'll protect her bones.
Great.
Yeah, and you ask about pain. As we already have mentioned, this is a silent disease until you have a fracture. There's some folks who have vertebral fractures or spine fractures, and they have a tremendous amount of pain, and in many cases that pain will resolve over 6 or 12 weeks, but in some cases it may not. There's a procedure called kyphoplasty where they actually insert a cement-type substance in the vertebral body, and that sometimes helps resolve pain. Sometimes patients who have chronic pain end up in medical spine centers and places that deal with chronic pain in the spine. Another common cause of pain with a fracture are sacral fractures or pelvic fractures. They can be very painful, and we do our best to treat them as we do many other pain patients.
Sure. Well, thank you both so much for taking time, educating us and the audience, and thank you for watching. We hope you enjoyed today's discussion. And to download our free osteoporosis guide and learn more about prevention and treatment options, please go to clevelandclinic.org/osteoporosis. And for more health news and information, make sure you're following us on Facebook, Twitter, Instagram, and Snapchat at Cleveland Clinic, just one word. And we'll see you again next time. Thank you.